Let's say Salman. Okay. On. पहले बता देने के लिए मतलब जिन्ना भी बढ़िया जो लोग हैं जो आ रहे हैं
जी जी सर इंट्रोडक्शन Assalamu alaikum and a very good morning everybody. It's a great pleasure to welcome all of you at Department of Ophthalmology, Jinnah Hospital, Lahore for today's academic session on glaucoma. As we all know, glaucoma continues to be a leading cause of irreversible blindness worldwide, and yet it often remains asymptomatic, silent, and thus dangerously overlooked. So this makes sessions like today essential, not just to enhance our clinical knowledge, but to refine our approach towards early detection and effective management. Today's session is going to be a great opportunity for us to revisit our basics, clear the misconceptions regarding glaucoma, to better understand the diagnostic tools, to discuss the latest treatment options, and most importantly, to learn from the expertise and experience of our honorable and respected seniors and teachers present here. So first of all, on behalf of Head of Department of Ophthalmology, Jinnah Hospital, Lahore, Professor Dr. Muhammad Hamad Ayub, Head of Department I Unit 2, Professor Dr. Usma Hamza, all faculty and team members of I Department, Jinnah Hospital, Lahore, I welcome our esteemed and honorable chief guest, Principal Akhtar Saeed Medical and Dental College, former principal and head of Department of Ophthalmology, Lahore Medical College and Jinnah Hospital, Lahore, Professor Dr. Nadeem Hafiz Bhatt. So thank you so much. We are so grateful for your presence here. You took time out of your busy schedule to join us, and we really look forward to learn a lot from you today. So let's formally start the session with the name of Allah. I would like to call Assistant Professor Dr. Muhammad Hassan Ali to please come on the podium and do the recitation of the Holy Quran.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم ولله جنود السماوات والأرض وكان الله عزيزا حكيما إنا أرسلناك شاهدا ومبشرا ونذيرا لتؤمنوا بالله ورسوله وتعزروه وتوقروه وتسبحوه بكرة وأصيلا إن الذين يبايعونك إنما يبايعون الله يد الله فوق أيديهم فمن نكث فإنما ينكث على نفسه ومن أوفى بما عاهد عليه الله فسيؤتيه أجرا عظيما صدق الله العلي العظيم وصدق رسوله النبي الكريم ترجمہ اللہ کے نام سے شروع جو نہایت مہربان ہمیشہ رحم فرمانے والا ہے اور اللہ ہی کی ملک ہیں آسمانوں اور زمین کے سب لشکر اور اللہ عزت و حکمت والا ہے اے حبیب بے شک ہم نے تمہیں بھیجا حاضر و ناظر اور خوشی اور ڈر سناتا تاکہ اے لوگو تم اللہ اور اس کے رسول پر ایمان لاؤ اور رسول کی تعظیم و توقیر کرو اور صبح و شام اللہ کی پاکی بولو اے حبیب وہ جو تمہاری بیعت کرتے ہیں وہ تو اللہ ہی سے بیعت کرتے ہیں ان کے ہاتھوں پر اللہ کا ہاتھ ہے تو جس نے عہد توڑا اس نے اپنے بڑے عہد کو توڑا اور جس نے پورا کیا وہ عہد جو اس نے اللہ سے کیا تھا تو بہت جلد اللہ اس سے بڑا ثواب دے گا وما علینا الا البلاغ
So many people couldn't join us physically, and they are attending the lecture through Zoom. I welcome all of them for. Thank you so much for joining us online. Now, I would humbly request Head of Department of Ophthalmology, Jinnah Hospital, Lahore, Professor Dr. Muhammad Hamad Ayub. Sir, please kindly come on the podium and share your remarks about today's session. Okay, notes, sir.
Thank you very much, Ma. First of all, I would like to thank my mentor, my teacher, and इस डिपार्टमेंट के मामार यही हैं, इन्होंने ही इसकी दागबेल भी रखी शुरू से पहले दिन के साथ और अब शायद थोड़ा बहुत हिस्सा जो हम डाल सकते हैं हम उसमें डाल रहे हैं लेकिन सर वी आर वेरी ग्रेटफुल टू यू आप तशरीफ लाए वैसे तो ऑफ्थल्मोलॉजी में एज सच जनरली सर की खिदमत बहुत ज़्यादा हैं लेकिन एज सच ग्लोकोमा की स्पेसिफिक फील्ड में जितना सर ने कंट्रीब्यूट किया मेरे ख्याल से किसी ने भी नहीं कंट्रीब्यूट किया होगा सो इट वाज बड़ा हमारे लिए खुशी की बात है कि सर अपने गोनागू मसरूफियात में से थोड़ा सा टाइम निकाल के हमारे इधर तशरीफ लाएं सर वी आर वेरी ग्रेटफुल टू यू आई एम वेरी ग्रेटफुल टू डॉक्टर नबील जो जिन्होंने टाइम निकाला है और हमें दे रहे हैं लेट्स सी के how we unravel the mysteries of glaucoma today right so glaucoma has always been a very mysterious disease or it has been called a sneak thief of vision आहिस्ता आहिस्ता आपकी विजन लेती रहती है और इसकी मिस्ट्रीज हैं जो कि अभी स्टिल काफ़ी सारी हैं जो अनरेवल होने वाली हैं एंड लेट्स सी के व्हाट कंट्रीब्यूशन टू आवर नॉलेज डॉक्टर नबील मेक्स इनको फॉर्मली इंट्रोड्यूस कराने के लिए मैं डॉक्टर इरफान को कहूँगा कि प्लीज कम टू द स्टेज एंड फॉर्मली इंट्रोड्यूस आवर गेस्ट स्पीकर टुडे
उधर ही पड़ा Bismillahirrahmanirrahim. I'm really grateful to Professor Nadeem Hafiz साहब कि उन्होंने आज टाइम निकाला हमारे लिए, and it's really an honor कि सर आज आए और he's among us. Dr. Nabeel, he's a young ophthalmologist, and I must say that while going through his credentials and fellowships, I really feel like that upcoming ophthalmological scenario in Pakistan would get benefit from him. He did his MBBS from Aga Khan University, then did FRC Opt and a PhD in Vision Sciences from National University of Singapore, and a fellowship in glaucoma, fellowship in medical retina, and fellowship in uveitis from SNEC. He has a fellowship in complex cataract and advanced anterior segment reconstruction surgeries. And as I just said, that PhD in sciences. So I'm really thankful, and I must say that this once again, even this session, like myopia session we had a few weeks back, would be very productive, and we will learn a lot of things today. Thank you. Welcome, Dr. Nabeel. Sure. Please.
It's fine, right? Shall we start? All right, so this is very humbling, as always, to become an expert and give a talk on anything. One day you're just a regular guy, and next day you become and then to sit amongst, my teachers, my mentors, directly or indirectly. This is very humbling. I'm really grateful to this department, to Dr. Hamad Saab and to Bat Saab, to, just honor us with their presence and welcome. I will do the best that I can. So, and within Pakistan, I did my graduation and training at AQU, and then I was very fortunate to work with Dr. Meher, who was our glaucoma teacher at AQU, Dr. Mehnaz, who's our glaucoma teacher at AQU. Those who know glaucoma landscape on a national level, they know who they are. And then to go abroad and work with the current global giants of glaucoma field. Dr. Ong Thin is current director of Singapore National Eye Center. Anybody who knows glaucoma on a global scale, he or she should know, who Dr. Ong Thin is, and Dr. Jonathan Craftsman. These were all our teachers, and they have. These people have answered many questions of glaucoma over the last 2 decades. If anybody talks about the contributions they have on a national level over the last 2 decades, this lecture would not just do justice. Anyways, so let's just kick off. Okay, so this is the layout of the presentation. I will briefly talk about the prevalence of glaucoma, and then we will just kick off with all the 6 questions that anytime any person has glaucoma query, he or she should answer those questions. Those questions are whether this is primary or secondary glaucoma, whether this is open angle glaucoma or closed angle glaucoma, whether this patient has or this person has high pressures or low pressures, whether the pachymetry, the corneal thickness, is it a thin cornea, is it a thick cornea, is it an average cornea, and what does the evidence say from an structural and functional point? Is it a pre-parametric disease? Does the disease only exist from an OCT point of view? Or we have some functional assessment and functional evidence of the disease on Humphrey's visual fields or even Goldman's visual field. And then lastly, and most importantly, I put that at the end. There is a reason for that. The optic nerve head assessment. Some people would just put it at the top, but I put it at the end just to emphasize towards the end of this talk. So anytime any person comes, we need to answer these 6 questions. We all might have been doing it, for doesn't matter for how long we've been associated with ophthalmology. Could be a decade, could be more than that, could be less than that. But this is just to make it, systematic. And the real audience, the real target of this talk is our trainees, the future ophthalmologist, and, to an extent, a comprehensive ophthalmologist, somebody who does not understand glaucoma. Because to be honest, when I kicked off my training, glaucoma would scare us. we would not even understand what glaucoma is. And a lot of times we won't even know how to label someone with glaucoma. It's not an easy diagnosis. To tell someone that you have glaucoma, and if you don't do anything about it, you might go blind one day. These are not easy things. So to reach that confidence and to reach that level and be very confident about it, that requires some skill, some knowledge, and some basic understanding of what the disease is, why it is such a diagnostic dilemma, and why we still haven't been able to crack the code for this disease. This disease is very old, since it's as old as cataracts. Well, everybody says Hazrat Adam ke daur se hai, right? So that's the reason. That's part one of this talk. How to be certain about labeling someone with glaucoma or not. That's part one. Part two, we talk about the solutions. What we have been doing for a very long time, and what's happening new on a global stage, right? So I won't spend too much time on global prevalence of glaucoma. I tell all my patients, glaucoma is 1% of the whole population. That means if right now the global population of the world is 8 billion, that means 80 million people have glaucoma. 8 crore. So if Pakistani population is 300 million, that means 1% of that, 3 million people have glaucoma. 3 million means 30 lakh, right? That's a huge number. It's really appalling and daunting at times. If the population of Lahore is 1 crore, 10 million, so that means 1 lakh, right? That's a huge number. We don't, this is developed world's data, right? This is not a data from low middle income country like Pakistan, right? All these figures are most of the times from developed world. We can just extrapolate these based on statistical models onto the population dynamics and population studies to the rest of the world. But this is developed world's data. It might even be more. Anybody who's been doing this for a long time, they know. The other important thing I would mention over here is more than 50% of the people, they don't get diagnosed. They don't even know they have glaucoma. They have done population surveys in the communities, random, go to, just randomly screen a community, 50% people undiagnosed. The reason is very simple. It's the silent thief of vision. This is not a cataract. If a patient has cataract, he or she will see you in your clinic. This is not diabetic retinopathy. This is not a refractive error. Those things are easily diagnosed, easily picked up, and to an extent easily managed. The biggest reason why glaucoma patients don't end up get diagnosed is because there's no symptom most of the times, especially in open-angle glaucomas. Because there is no symptom, they don't realize, and by the time the symptomatology becomes clinical, it's already too late, right? We cannot control the disease. So it is the leading cause of irreversible blindness across the board. Throughout the studies, cataracts, refractive errors, yeah, sure, they make up a huge chunk. Those are reversible causes. Amongst all the irreversible causes, as of 2025, glaucoma is the leading cause of blindness, irreversible blindness. And the numbers are huge. The numbers are extremely huge. The current projections say, as I mentioned about, this is 2020, so it's about 2025. So 1% population, they would just continue to grow. It's a disease of the aging population. As everybody knows, the aging population globally has been increasing steadily over the last few centuries. We have higher number of older people more than 40 years, 50 years, 60 years. The numbers are steadily increasing. That naturally results into higher number of patients with glaucoma. All right, now let's kick off with the basic question why or what we need to answer anytime a patient comes to us. The first thing we need to answer and we need to ask ourselves, what is this disease pathology that I'm looking at? Is it a primary mechanism going on, or is it a secondary mechanism going on? Is this an open mechanism, open angle pathology that I'm dealing with, or is this some form of closed angle pathology I'm dealing with? The reason these two should be the first and most important questions in anybody's minds is because Secondary glaucomas, they fare worse than primary glaucomas. Closed angle glaucomas, they fare worse than open angle glaucomas. Patients who become blind because their numbers are more than 70 and 80% in even primary closed angle glaucomas. Most studies, they put the numbers somewhere about 20 to 30%. Out of all the glaucoma in the world, good 20 to 30% glaucoma is a closed mechanism pathology. Out of those closed angle pathologies, most patients end up blind forever. When we say blind, we're talking about legal blindness. Somebody's vision is worse than 2200. Now, these facts and these numbers, because we're ophthalmologists, we're clinicians, we have had these talks, we did our exams, we did our studies. We keep hearing these numbers and we tend to develop this thick skin. We don't realize this until one of us or somebody close to us, they get diagnosed with this disease. And then the guy says, oh, there's nothing I can do. We'll talk about this in part 2. Whatever is gone is gone. So the thing about the real reason why I really agreed to this talk was because we can do something about this only if we are right about it. The first thing we need is the correct diagnosis. If we don't have the correct diagnosis, we will not be able to understand the progression of the disease. And if we don't have the correct diagnosis, we don't know how to progress the disease, how are we going to manage? So the real thing that I want to stress about over here is the correct diagnosis, understand the pathology of the disease, because secondary open-angle glaucomas are totally different beast compared to a primary open-angle glaucoma. Closed-angle glaucoma is a different entity from an open-angle glaucoma. All right. So we can label pretty much about primary, secondary, and open and closed by 2 things. We need to look at the anterior segment of the eye, and we need to look at the angles. We can look at the anterior segment of the eye with a slit lamp. Everybody has access to a slit lamp, right? It could be a handheld version. If we're dealing with a pediatric population, we would just take the patient to the OT. We would put them under anesthesia, and then we can easily look at the anterior segment. What most patients, what most people, what most clinicians, what most optometrists, what most ophthalmologists, and these things are painful for me to say, they don't do gonioscopy, right? And the reason they don't do gonioscopy, it's a multifactorial reason. All over the world, even in America, they did studies. Comprehensive ophthalmologists who have been dealing patients for a very long time, they don't do gonioscopy. This is America I'm talking. We cannot just point fingers at anybody. We cannot point fingers at the systems. We cannot point fingers. This talk is for me, how I can do a better job from today and tomorrow. When we talk about gonioscopy, it's a skill. Just like anything else in life, there's a learning curve. It can easily be learned. All you have to do is to understand what I'm learning and be scientific about the whole process. I will try to go through this, the basics of it, just to make everybody realize and understand how important it is and what are the pitfalls that we do. Even the ones who do gonioscopy, what are the things that they are doing wrong? And because they never heard about it, probably they just don't understand it. So the first thing is direct gonioscopy versus indirect gonioscopy. Direct gonioscopy means we need total internal reflection laws. I'm not going to go into details of the optics to look at the angles directly. We need a prism for that, a contact prism. There used to be a very good TP prism back in the days. It's not available anymore. So in the clinic, we can do indirect gonioscopy. There are many ways of doing that. There's a single mirror gonio lens, 2 mirror, 3 mirror. All these lenses have mirrors in it, and they need the ones which are non-flanged. Those, they do not require even a coupling agent. One just needs an alkane drop and just anesthetize the patient comfortably and just puts up a 4 mirror on the cornea of the patient. The contact area is about 8.6 millimeters, 9 millimeters, and then one can easily look at all the 4 quadrants. If one does not have access to the 4 mirror, it's very hard to do what I'm about to talk next. That is the dynamic gonioscopy. Everybody can do static gonioscopy. When they start doing it, doing static gonioscopy is very easy. Static gonioscopy means I put the lens on the cornea and I look at the angles, and then I make my judgments or assessments. Okay, I can see up to this much, I can see up to this level, I can see up to this level. But we need to separate open pathology from a closed pathology. This is not a useless test. Just by doing this test, which barely takes a couple of minutes, we can save someone's life. We can save someone's vision, because this is a closed pathology. If closed pathology is picked up early and timely, these patients can be off treatment, for a very long time. So the ideal thing to do, dynamic gonioscopy, is a 4 mirror. It's not that expensive, I mean, it is expensive in a way, but if one is going to do a comprehensive ophthalmology for the rest of their life, they should just invest it, for good. There are many classification systems. I'm not going to go into details. Whatever makes anybody comfortable, right? I have my own system. The guy next to me can have his or her own system, and the person, whatever makes you comfortable, as long as one knows what they're looking at and they know what they want to see. So that's really important. So anybody can go through all the four systems, and whatever is comfortable for them, and it doesn't even have to be a system. One can just write, whatever they see. The angle, the orientation of the iris, the structures they are visible, and other things. All right. Now, okay, I'm going to spend some time over here. Most people do gonioscopy in a light environment. They don't do gonioscopy in a dark environment. When we do gonioscopy in a dark environment, that's when we really see what is happening at the structure. So this is the same patient. Dr. Cyril from Mayo Clinic, he did some amazing research back a couple of decades. This is the same patient. Same patient, light environment. When they close the light, this is a UBM, ultrasound biomicroscope of the same patient. The angles close. If the room is lit up, then we are not going to see that. We'll just label this guy, oh, it's okay. The angles are open, fine. I'll see you after 1 year or something, because the pressures are normal. Because I did not even pick up the disease. Everybody has this. We spend half our days in a dark environment. So we have to do gonioscopy in light environment. We have to do it in a dark environment. Otherwise, we will miss pathology. The whole point of doing gonioscopy is diagnosis. And if we're not doing it right, we will miss the diagnosis. All right. Okay, so when someone is kicking off, we would always tell our trainees, residents and the initial medical officers and everything, just get a 3 mirror, get a big Goldman 3 mirror. Just learn to identify the structures. It's just easier that way. Once you're able to identify the landmarks and the structures, then you move on to do it right. Then you move on to a 4 mirror, and then you can, do the indentation, and then do the light versus dark. Initially, just get a 3 mirror, make yourself comfortable after first 50 to 100 cases of patients, because there are many nuances. You have to anesthetize the patient, the position has to be right, one's arms and elbows need to be right. There's so many things. We can even do a whole workshop on it. I won't mind doing that, because it's that essential of a skill. We can just call patients and just call the residents and just make them do it. It's that important. Well, there's so much that we miss out by not doing it right. So the pitfalls that a lot of people do encounter is, these are the pitfalls. We don't have this problem so much in Pakistan. In Caucasian patients, we used to do encounter that. So sometimes the trabecular meshwork is really light. So it's very hard to make the landmarks. All right. The second pitfall is some people don't know where the Sanfilippi lines ends and where the trabecular meshwork starts. And last but not least, people, when they're kicking off, they would just assume iris processes to be peripheral anterior synecdoche. All right. Okay. All right. So an easier way to, because when someone is kicking off, these things are important. When someone is, they have the skill down, then they don't even remember these things. So where the line, the split line over the cornea ends, that's where the meshwork starts, right? Anything above that is the Sanfilippi line. Anything above that. So this is the meshwork. This over here, the pigmented line, that's the simple easy line. A lot of people will just confuse this. Oh, okay, sure, it's a very, no, that's not the case. It's over here. This is only after indentation that this angle opened up. This is the same patient without indentation. This is sample easy line. If someone would confuse this sample easy line as meshwork, they would say, oh, the patient has open angles. This patient does not have open angle. He has appositional closure of the angles. Only when we did, the angles opened up. Second problem a lot of people have is this. What are these processes or are these synecdoche? It takes a while to get a hang of it. Some people are very clearly, the processes can be easily picked up. The second thing is, these are the RSs. The RSs could be, high rise, low rise. There's like tinting of that. It takes a while to get a hang of these things. It takes a while. So this is a very lightly pigmented guy. We don't have this problem in Pakistan, luckily, but every once in a while you might come across a patient where the meshwork is really light and you don't know where the landmarks end and you know where the angle structures kick off. All right, so we all know this structure. I'm not a big fan of Van Herrick. Why? Because a lot of people, they would just do a Van Herrick on slit lamp and they would say, oh, I don't need to do gonioscopy. Anybody who thinks like that is wrong. Van Herrick cannot substitute gonioscopy. Nothing substitutes gonioscopy. We'll talk about the role of ultrasound biomicroscopy and anterior segment OCT. But even then, we miss out so much by looking at visualizing the angles directly with our own eyes. We miss out the blood vessels. We miss out the appositional element of the closure. Okay. So whatever system works for you, just stick to it. Okay. And there are so many systems. Some people say anterior trabecular meshwork, posterior trabecular meshwork. Some people say scleral spur, ciliary body band. Whatever works for you, just stick to it. And do make a comment. Make a habit of making a comment. A lot of people, what they have done is they've started ordering anterior segment OCT, and they will just get this angulation, and they think they can substitute gonioscopy. It cannot. Why? Because there is no dynamic element over here. There is no element of light versus dark over here. We have to tell the technician to get the anterior segment OCT of the angles in light and in dark environments. Only then we would know the difference. Most technicians over here don't even understand this concept. They've never even heard of it. All right. So the other thing is 10 degrees, 20, 30, 40, 50. A good glaucoma specialist would do gonioscopy on even open angle glaucomas at least once a year. Why? The lens is going to become cataractous. It's going to swell up. Somebody who has 30, 40 degrees of angulation today, it could become 10, 20 degrees. Someone who has open angles today can easily and naturally just have closed angles in the future. If you just do gonioscopy on a patient once and that was it, and then one never does it, that's wrong. That's missing out. Okay, so this is an indentation gonioscopy. Over here, the angles are closed. When we indent, they open up. Okay, these are just few pictures. There's a very good resource available online, free of cost. A professor from University of Iowa in America, Dr. Lee Alvarez. It's called gonioscopy.org. I would strongly recommend everyone to go through it to get the knowledge base down, and then just get anybody who's good at it to just go through with you. How to do it, how to appreciate the structures, how to see when the angles open up, how they open up. All right. This is just a patient. This is just what happens when we do peripheral laser hydroplasty. I just wanted to show this picture. Sometimes it does open up the angles. Okay. All right. So these are just some forms of secondary open angle glaucomas. Very densely pigmented meshwork. People tend to grade it. Oh, +1, +2, +3, +4. This is a subjective assessment, but it's really important. And this is just an angular recession, which is also a form of secondary open angle glaucomas. Angular recession just simply means that there was some form of traumatic pathology that happened over there, and that is it. I mean, it's the word angle restoration is a misnomer as far as the diagnosis is concerned. It just says the pathology, that meshwork on that clock hours, it's damaged. Okay, all right. Now I'm going to spend a couple of minutes here. We say somebody has primary angle closure suspect when the pressures are normal, but there is iridotrabecular contact, ITC, more than 180 degrees. But the pressures are normal. When the pressures start going up, we label it as primary angle closure. And when the patient develops some form of damage of the optic nerve, then we label that person as primary angle closure glaucoma. It's a spectrum. It's a continuous spectrum. Anybody we see today who is PSEG today was PSCS sometime, was PSC a while back. So we really need to pick that up. Okay. This other important thing over here is PSCG usually presents either as an acute form. Everybody's aware of that. That red eye with headaches and halos coming to ER2 at night, right? During training, everybody gets that call. We all know that. Oh, you're having an acute angle closure attack. Most people think that angle closure glaucoma presents as an acute attack. They're wrong. Most of the angle closure patients, they present as what we call subacute angle closure glaucoma. The history gives us that clue. These are the patients who would have attacks and they would resolve on their own. This is the patient who would come to you and tell you, oh, Dr. Saab, I've been having headaches for a very long time, for the last 5 years, for the last 10 years. Every time I get a headache, it usually lasts a couple of hours, usually lasts half an hour. I've seen neurologists, I've seen physicians, and they all say, they put me on medicine, but I don't know what's going on. And if that person ever ends up with an ophthalmologist, because the attack is gone, so the pressures are normal. And all we would do is just, Van Harry. So a patient tells us repetitive history of headache or even first-time history of headache, and we did not do gonioscopy on that person, we miss that diagnosis. So that's the most common. If they have done studies on this, the bulk of patients with angle closure glaucomas is subacute presentation. They don't get diagnosed. They would even give the history of that, and they would only get picked up when it becomes chronic. And when it becomes chronic, there's already damage to the optic nerve. The pressures are already starting to stay high. That's when the glaucoma. That's when the ophthalmologist would say, "Oh, you have high pressure. Let me do gonioscopy on you." And then he would say, "Oh, I think you have some appositional closure." Appositional closure means we can break that closure just by applying force. So there are two types of closure in an angle closure glaucoma. It could be appositional or it could be synechial. Synechial means we cannot break the contact between the iris peripherally. That's a synechial closure. Once it's done, it's done. Okay. But the other form is the appositional. The whole point of dynamic gonioscopy is to separate the two from appositional compared to the synechial closure. Synechial closure is permanent. We can only surgically remove it, but even that's a challenge. These RSAs, we can do goniosynechialysis on them. They will just close back again, even if we do cataract surgery combined with it. So that's that. The other thing is the mechanism. Either it's a pupillary block mechanism or it's a plateau configuration mechanism. Pupillary block can be relieved just by doing, everybody knows that we all do, laser peripheral iridotomies. We can just zap it with a YAG laser. We can, thin out the cornea, work at the cribs peripherally. There are even studies on it. 10% of patients have these linear dysphotopsias. So they would say, don't do it at 11 o'clock or 1 o'clock, just do it at 3 o'clock or 9 o'clock. It tends to help with the linear dysphotopsias. If someone has done this for a very long time, they would understand what I'm talking about. So these patients, because of the opening superiorly, the light would just go through it the tear film acts as a prism, and these patients have this really bothersome, annoying linear dysphotopsias. And their life is miserable because they cannot see clearly. So a lot of times, we even have to tattoo the cornea over the opening in such patients. So they did a study teacher, mentor, Ikama did the study and he came up with this scale. If we just switch to 3 o'clock or 9 o'clock, the rate of linear dysphotopsias goes down. That's the pupillary block. The other thing, which is very hard to understand and grasp the whole concept of it, that is the plateau configuration. I should have a couple of pictures of it. Okay, so plateau configuration, every time a patient comes to us and we do gonioscopy and we do the typical double hump sign and we say, okay, there's anterior placement of the ciliary body band, and that's why you have this plateau configuration of the iris. Let me relieve the pupillary block. So we do LPIs on that patient, or we would do cataract surgery on that patient. If it's relieved, good. If it's not relieved, some authorities have suggested even doing peripheral iridoplasty on such patients. We would just zap out the irises and just make it thin, as I showed you in the previous picture. Sometimes even that does not work. So recently what he proposed was this mid-peripheral 360 cerclage of such patients, and that takes care of it. Because this iris, the ciliary body band is placed so anteriorly that it just keeps up, appositioning. And eventually these patients develop glaucoma. Okay, all right, so there has been these trials. Dr. Ongtin was involved in these trials, ZAP and Analyze. Analyze was done in Singapore, ZAP was done in China. They did this on, lots of patients, thousands of patients, and they would just do LPIs, prophylactic LPIs in PACS versus, and then against control people who were just PACS patients, but no LPIs. And they did see that there is 50% reduction of glaucoma development, but the other take-home message was 10% of patients who did not have LPIs eventually developed glaucoma, compared to the 5% of patients who did have LPIs, they did not develop, they only 5%. So the significance, these are one of those things, where you sits down with the patient and gives the patient these options. We are labeling you as a PSCS patient. We can open up the angles for you, or we can just observe it. So whatever you want us to do, we will do it for you. This is where that biopsychosocial model of care comes into play. And the EAGLES trial was done on primary angle closure glaucoma patients, and they proposed, it's a really good, robust study, but it did not answer clear lens extraction questions in patients with PSA or PAC. They did clear lens extraction in patients who already had glaucoma because of angle closure, and the results were amazing. The glaucoma was taken care of even without meds. But there hasn't been any study which is done on PSCS or PSC patients for clear lens extraction. That's that. And we have to do, after doing LPIs, we have to do gonioscopy. And just having a hole or just having a transillumination positive response does not tell us that it's patent. We really have to look at it, and it has to be a black dark hole. Only then we can be sure, okay, all right, initially the two cords were closed and now one is open, so it did work. Only that way we can be sure. And we have to serially monitor these patients. We have to do their gonioscopy repetitively. Okay, that's that. And the second part is about these open angle glaucomas versus secondary open angle glaucomas. Those include pigmentaries. Pigmentary glaucomas, patients have pigmentary dispersion syndrome before they develop the glaucoma. 15% of patients who have pigmentary dispersion syndromes, they go on to develop glaucoma. Likewise, pseudoexfoliation glaucoma, which is a form of secondary open angle glaucoma, they have pseudoexfoliation syndrome before. These are very challenging cases. 50% of those patients go on to develop pseudoexfoliation glaucoma. The surgery is very challenging. A lot of times these patients need sutured back fixation. Even if we manage to somehow put the lens in the bag, these are the patients who are going to subluxate or dislocate a couple of years, because the disease of exfoliation is a systemic disease. It's not cured. We just took out the cataract. Another big challenges are the neovascular glaucomas. A lot of neovascular glaucomas kick off as secondary open angles, and then they go on to develop secondary angle closure glaucomas. Likewise, a lot of uveitic glaucomas. These are very challenging cases. A lot of times these patients end up getting the tubes right away. That's your first line choice, because it's just the disease is so advanced, they don't get picked up. Neovascular glaucoma causes include, PDR, ocular ischemic syndrome, central retinal vein occlusion, but nobody counseled them about glaucoma. They would only be counseled about glaucoma when the pressures hit 40. If PRP is done at the right time, the glaucoma can be inverted. Everybody knows that 90-day glaucoma. Patient comes to us with a CRVO, 90 days down the road, he or she is going to develop glaucoma. Nobody does, people would just delay even PRP. So that's that. Okay. All right. So the second part is I'm going to rush because it's a lot to cover. So high versus low glaucomas. Not all glaucomas are high pressures. Initially everyone thinks the glaucoma is all about IOP. It's not. It's a progressive neurodegenerative optic neuropathy. That's what glaucoma is. It could be a high pressure glaucoma, or it could be a low pressure or normal pressure glaucoma. Some glaucomas some patients are always in their 20s. Some patients are always in their 30s. Some are as 40s, and some are just in their 50s. Everyone has, if they've been doing this for a long time, they've seen those patients, where the pressure is more than 60s or even 70s. Now, the reason this is important is because it changes the management. Every optic nerve is different. Some people have robust optic nerves. They don't even progress even if the pressure is 30. The RNFL stays the same. Compared to another person who is even progressing at the maximum pressure is 25. Every optic nerve behaves differently to IOP. For some person, even 30s is reasonable and acceptable, and the optic nerve remains robust. For other guys, even a pressure of 20 and 25 is unacceptable. So we have many ways of measuring the pressure. The gold standard is Goldman applanation tonometry. It assumes that cornea is flat relatively. So if someone has a very high astigmatism, something more than -2 diopters of astigmatism, someone has -3 or -4 or -5, the safest way to do that is to just take it across two axes and just average it out. Right. The other thing we used to do use these eye care a lot. It's a Finnish instrument. It's really amazing. It has this monofilament. It really helps us take glaucoma pressures even in a 2-year-old kid. We don't have to sedate them and take them to OT. It's quite comparable to even GAT. It is a bit expensive, but I mean, training institutes and tertiary care hospitals and somebody with good practice, they should have these instruments. It really amazes me sometimes when we would go to an eye hospital and the person doesn't even have a GAT on his slit lamp. It's just amazing. Or if a person comes to they're in a bed, if a bed-bound person comes to me, how am I going to take his pressure? I need eye care. I need Perkins. I need Tonopen. I need some way that I can take the pressure of a person who is lying down flat. If I want to take the pressure of somebody in the ward, I need some instrument. I'm not going to have that patient, sit upright and, just bend forward and look at it. It's just not possible and feasible. So that's that. There's even, dynamic contour tonometry. Ocular history says that there's even ongoing research about some new contact lenses who are measuring. They're looking at ways to measure because the concept of IOP phasing really comes into play. If I want to label somebody as normotensive glaucoma, I want to be sure his or her pressures never shoot more than 20 or 21 or even 24 for that matter, right? The only way I can be sure of that is if I address that diurnal variation. And the only way I can do that is by measuring the pressure. I'm not going to pick up my slit lamp and go to the person's house at night. So what we would do is we would just give them, lend them this eye care device. So the husband would do his wife's eye care throughout the night. They would just do a couple of days and then they would come and then we have a very clear picture. Okay, all right, we are not dealing with somebody whose pressure shoots up more than 10 millimeters of mercury or 15 millimeters of mercury. A lot of patients, every time a patient comes to the clinic, it's 10. But we have an, 2 a.m. reading of 26. Okay, we are not dealing with normotensive glaucoma. We are dealing with open-angle glaucoma. Why? Why is that important? Good 40% of patients with normotensive glaucoma, they don't progress without any treatment. Syntax answer helped us answer that question. So these are those nuances which make all this even more challenging and important. And if we have a kid and we're taking that person to the OT, the person is under anesthesia, we need some form of Tonopen, Perkins, or eye care to take the pressures. All right. All right, so everybody knows these vascular pathways, the traditional pathways. Okay, so the other thing I would like to stress over here is this: do it right. We need to use fluorescein. I mean, it amazes me how sometimes people will just have been, just doing the IOP just with a simple drop of alkane. You cannot get it's very thin. We cannot get these Myers. Cannot be too much, cannot be too less. Has to be the right amount. Okay, the patient has to be comfortable, and so these are those nuances. And the upper lid, the patient needs to breathe. A lot of patients, they would do Valsalva and the pressure would go up. A lot of times the person who's doing it is not doing it right. He's just pressing on the orbit directly himself. These are things that can give us false readings. The other thing important is sometimes, I mean, our brown people don't have this problem. We would have this over here. Some people have very tight orbits. The closer to that over here is the sunken eye. It's really hard to do it right in a very deep sunken eye. We have to adjust the patient's position. Has to be in the straight gaze. If the patient gazes moves, the pressure changes. Right. So these are those little nuances I would highlight. Okay. All right, so this is the right position. The inner edges of the Myers should touch. This is not right, and this is just too far apart, and it's very too little of fluorescent. Okay, all right. The other important thing is thick corneas versus thin corneas. Average corneas are about 550, 560. Oates helped this ocular hypertension study a couple of decades ago helped us answer this question that thick corneas are protective. When we say thick, we say somebody more than 580, somebody more than 570, somebody more than 600. Now, we can measure the corneal thickness through by ultrasonically or even optically. A lot of times, it's just amazing that somebody has been diagnosed with glaucoma, is being managed as a glaucoma patient for a very long time, but there is no record of his or her corneal thickness. Why is that important? It's very simple. Someone with thin corneas, my IOP lowering my target IOPs would be lower, and someone with thick corneas, well, okay, I can give some leeway to that patient. This becomes even all the more nuanced because we have increasing prevalence and incidence of myopia, and everyone thinks ophthalmology is all about taking out cataracts and just doing refractive surgery. We have thin corneas. After someone has had their refractive surgery, the pachymetry is usually in 400s. So that's a thin cornea. Now, if someone with a cornea of 420 micrometers and the patient has a pressure of 18, now that's not a normal pressure for that patient. My targets will naturally be go down. There are some authorities, it's not robust data. They have these conversion formulas. I don't usually follow them. I don't tend to follow them personally, but one just documents it. This is the pachymetry of this patient, and we need lower IOP targets. And if someone has thick corneas, okay, we can be okay with targets. This becomes all the way more important in patients who have corneal pathologies. Doesn't matter if the patient has pseudophakic bullous keratopathy, Fuchs, stage 2, stage 3. These people have swollen corneas. We need the thickness of the cornea. So we need serial measurements of the corneas, because someone who has a thickness of 800 micrometers and his or her pressures are 10 today, okay, I'd be worried about hypotony in that patient, right? And when the swelling goes down and it's still 10, okay, it's something else. So these are those nuances. When we deal with complex patients, when we deal with complex pathologies, the thickness becomes even more important. All right. Now we're coming to the diagnostic, the last two, which everyone thinks what glaucoma is about, is OCTs and visual fields. Now, OCTs can help us pick up glaucoma and nerve damage, what even human eye cannot see. Everybody knows by the time someone has functional loss of vision on a visual field, 50% of RNF damage has already occurred. We have had this data for more than decades. That's one thing. Second thing is, we need to understand the limitations of these testing modalities. We need to understand the differences between Heidelberg and OptoView and Cirrus And we need to understand the normative data sets. We need to understand the false positives and the false negatives. This is true and applicable for both OCTs and visual fields. Now, green disease is a false negative on an RNF, on an OCT. Green disease means a patient comes to me and his nerve is, okay, 120 micrometers. All right, good. The patient comes to me 6 months down the road, his nerve is 115 micrometer. So there is a loss of 5 micrometer. In how much time? 3 months, 6 months. Now, the OCT says this person has normal RNF. No, he or she does not. The normal loss of RNFL thinning in a normal healthy individual is about 0.2 micrometers. The way I remember is, in 5 years you lose 1 micrometer, right? But this patient lost 5 micrometers in 6 months. So this patient has glaucoma. The disease is progressing, but it's a green disease. We go to the flip side, which a lot of people confuse. This becomes even more of a challenge in myopic patients. Myopic, we know it's a stressed eye, right? Axially elongated eye. So a lot of times OCT will say, oh, this patient has RNF thinning. No, he does not. I will go through the pictures and I'll show you the data. They have even published myopic normative data set, right? Different platforms and different data sets, but the population, even the multi-ethnic population they chose was normal, E-metro population. It was non-myopic population. So we need to be very careful about red disease versus green disease in OCT. We need to be careful about the common false positives and false negatives. Some people are trigger happy when they're doing visual fields. It's a white field. One can never get a totally white, bright field. Some people are just, tired and they doze off, and we see these clover patterns. I mean, this requires series of thoughts, right? I was just trying to go through this, but anyways, I just wanted to mention this. And there's a role of electrophysiology. It hasn't switched and converted into clinical means, but we have data that multifocal ERG and pattern ERG can pick up RNFL loss even when the RNFL and ganglion cell interplexiform there or ganglion cell complex was totally normal. It is that sensitive. How is that translated into clinical? We have yet to see that. But electrophysiology does give us objective functional loss of vision even before OCT. All right, now the other thing I would want to clear up over here is different platforms with different ways. GCC is what OptoView uses. It is a combination of GC-IPL plus RNFL at the macula. But Zeiss only mentions GC-IPL. It subtracts the RNFL layer from that. So that's that. Most of the times, the loss at GC-IPL level, it precedes the RNFL loss, most of the times. I will go through the pictures when sometimes it's the other way around. The RNFL loss next to the optic nerve head precedes the GC-IPL loss. So if when we're really in doubt and we want to be sure because of the risk factors and the family history and all of that, so we need to order all of this. Okay. All right. So this is the macula. We have, good sensitivity of GC-IPL over here. We don't have that in the peripapillary region, right? So that's why we can really pick up the disease quite early over here. Okay, this is a normal healthy macula. These are very normal healthy nerve bundles. Okay. All right. So these are the different platforms. Zeiss has the robust normative database of multi-ethnicity. A lot of people don't really know this. Heidelberg only has Caucasian data set. We are brown eyes. We are not Caucasian eyes. Well, brown eye is a different eye form of Caucasian eye. Their data set is only Caucasian population. Okay, and I mean they've been in the market for since day one, but they haven't changed their normative database. OptoView and Alcon Trident, they have that multi-ethnic, but the most robust data set is from Zeiss. That's one thing. Second thing is I already went through this green, red, yellow. Red, yellow means the fifth percentile of people who have early. So sometimes we have green disease, sometimes we have yellow disease, and sometimes we have red disease. We need to be on the lookout for that. How all these different vendors map out, one has to look at these scans a couple of times to get a hang and feel of it. Okay, all right. It should all match up. The appearance of the disc, the IOP, the history, the OCT data, the visual field, the angles, right? The thickness of the corneas, everything should tie up together. It's not like someone has very advanced disease on OCT, but his disc looks healthy. Okay, something is off. It's not like somebody has very advanced damage on the visual fields, but his OCTs are normal. Okay, something is not right. It's not like someone has glaucomatous optic neural disc, but the OCT is normal, right? All should tie each other up. They have this, they show the deviation map. So this is a healthy bundle. Yellow, red is healthy bundle. And over here, so it shows, so these two add up, right? They corroborate. But if we would just focus over here, it just shows it's a healthy nerve, right? One would miss this out. If someone would just look at this global graph, okay, they go, oh, all right, this patient does not have glaucoma. That's a healthy nerve. No, look here. We need to look at this area. Why? We need to look at this area. This is the same patient. This patient actually has even subjective, losses. This is the same patient. This is the global circumpapillary profile nerve of the same patient who already has, it corroborates inferior RNFL loss and superior, nasal step superior defect. This is the same patient. Same patient. One can even, appreciate, look at these white striations over here, healthy RNFL, fibers over here. Look, compare the top to the bottom. The last part of this talk is about how to look at the optic nerve, but I will go through this again. But one can appreciate. It's not the classic dark wedge shape, but one can appreciate the top from the bottom. He has that loss. It's even clinically evident. But if one would just look at the green, he's fine. He doesn't have glaucoma. All right. So the most important thing is that look at the signal. Okay. Look at the signal. Look at the signal. Look at the signal. A lot of times, media opacities decrease the signal. Every platform has their own way of. Zeiss has up to 10. Some people have up to 50. Many platforms have their own signal strength. This is the same patient. Okay. It's like, okay, he probably has glaucoma here. Took out the cataracts, and now the nerve bundle becomes healthy. Why? Because of the signal. The signal is 9 over here. It was 5 over there, right? So one has to be very systematic and thorough. Look at the signal. Look at the patient. Okay, if it's the same exact patients who are sitting in front of you, it's the same patient scan. Verify the data. Look at the signal strength. That's step one. That's most important. People just jump to here, right? Okay, it's all green. Fine. They don't go through this in a systematic manner. So that's where they miss out. All right. So this is what I was talking about. That the progressive loss precedes GC-IPL thinning precedes the RNFL loss. That's the case most of the time. This is the same patient. This is the same patient. If we just follow this up over here, okay, there's loss over here. There's loss over there. He already has started loss over here, right? This is the deviation map. But the same patient had evident loss about 2 years apart, right? So the GC-IPL loss predated the RNFL loss. Okay, and sometimes it's the other way around. A good reason for that is the size that we take. Over here, this is the same patient, right? The RNFL loss was in 2010, but 3 years down the road, that's when we measure. The reason why we can easily mess that up is the size of this cube. Okay, macro scales are only 4.8 millimeters. So if someone has a wedge-shaped defect over here, we can only pick it up on the RNFL deviation maps. We cannot pick it up on GC-IPLs. So sometimes it's the other way around. One just has to be on the lookout and watch out for that. Okay, second thing is the correspondence. I went through that already. And so this does not, okay, the second thing. All right, so part of that is, we have to look at the nerve. Look at this nerve. That's a healthy nerve, okay? It's a myopic nerve, but it's a healthy nerve. It's tilted. Most myopic nerves are like that. They're nasally tilted. Sometimes they're superiorly tilted. Sometimes they're inferiorly tilted. But look at this nerve. It's a healthy nerve, but it shows disease over here, right? So that's a healthy nerve. You would not label this patient to have glaucomatous damage just based on this one scan. Everything should tie up. Raymond did studies. I went through this point already. This is the same patient. Same. Look at that nerve. That's a healthy. That's a nasally. Look at this orientation. All right. It's a temporally tilted nerve. Very healthy nerve bundles. Normative database showed red disease. Myopic data said, oh, that's fine, right? Not a lot of vendors have printed it out. It's still not globally accepted, but it's a known fact. All right, so these RNFL defects are wedge-shaped, right? They're wedge-shaped. And one needs to be on the lookout, one needs to make the comparisons. Look at these white striations. All right, okay. This is RNFL, optical. I will go through this again. All right, okay. And so it's very healthy over here. Look at that loss over there. Same patient already has those visual losses. Same patient, nasal steps. Okay. All right. So a lot of times patients can have healthy bundles, but they already have the loss. Okay, I've already made that point. Next up is okay, same thing. All right, yeah. So neuroretinal rim assessment. Now this concept of Brooks membrane opening, we cannot look at the Brooks membrane opening clinically or with the human eye. So the machine does it for us. And then, but this is only for emetropic eyes, for normal optic nerve heads. Okay, these are not for diseased eyes. Okay, this data would be totally off, right? So they have these landmarks where they look at this Brooks membrane opening, and then from there on, they do this width assessment. Okay, it's just a topographic landmark. Okay, based on that, they get the minimum rim width, and then they give the analysis. Okay. All right. So this is the same patient. Right eye, left eye is pallor. Pallor means the pallor of the rim. Okay. There's pallor of cup and there's pallor of rim. I'll go through this next one as well. Pallor means this is probably not glaucoma, right? Most glaucoma people, if they just look a pale disc where the rim is pale, okay, they know it's not glaucoma. Something else happened to this patient, right? The RNFL would show loss, right? Because the nerve is pale and thin, but it's not glaucoma. So not OCTs and visual fields, they do help us differentiate between glaucomatous optic neuropathy versus other neuro-ophthalmic causes of optic neuropathy. Okay, all right. I think I've gone through these points. Okay, same patient. All right, so this is not clinically commercially available, but it's an amazing tool. It's called ROTA, optical texture analysis. It really maps out that nerve healthy bundle, which we all know, have seen that picture. It really picks up the losses even before the OCT does. And the same machine gives us this data. This is a real humanized data. Looking at look at these high resolution. Look at that healthy nerve bundle, right? So I mean, we can only hope that this module of these machines becomes more commercially available and accessible. Okay, all right. So for visual fields, we have the structural assessment of the nerve and the macula from an OCT. Now we want to look at the functional bit of it. So visual fields help us do that. The common platforms are ZEISS and yeah, so we have these concepts of static parametry versus kinetic parametry. Most patients have this learning curve of doing a reliable visual field. It takes a while to get a hang of it, takes a while to do it right. But once patients have a hang of it, they can do very reliable visual fields. And if someone can do reliable visual fields, we will just stick to that patient on that same parameter. But if after trying maybe like 5-6 times and the patient cannot do reliably visual fields, I would just switch to kinetic parametry. Okay, kinetic parametry. I mean, I've found that there was only one guy who does that in Punjab, in Lahore, but it's more operator dependent. But it can really get more field out of the patient, right? The famous one is Goldman visual field, which is totally kinetic, and it really looks at the 180 degrees. But the recent automated version of it is by the Heidelberg, which is called, I think, something HPF 9 or something. There's a fancy name for it, but it's available. It's in the market. It looks at the 90 degrees fields. Okay, I went through the artifacts, and so we have to classify the damage: mild, moderate, severe, advanced. Up to 5 decibel, 6 decibel, mild; 10, 12 decibel, moderate; 15, 16 decibels, severe; more than 20 decibels, advanced. So we need to have a very clear picture of where our patient is today, how he or she is progressing. We need to do visual fields a bit frequently in first 1 to 2 years of the presentation to get an idea. How is this patient? How does he fit into the bell curve? Is he one of those 3 to 5% fast progressors, right? So we need to have that. There are many parameters: 24-2, 10-2s. 24-2s have barely 4 points in the central macular area. So they've come up with this new algorithm of 24-2C, where they have more macular points. Sometimes early macular losses are not picked up by a simple 24-2 algorithm. So either we would just order 10-2 settings, or we can just get 24-2Cs. There's that. The other thing is the stimulus. Someone has vision worse than maybe 636, 660. I would just switch that patient to a brighter stimulus, right? Just to get fields out of it. We can even look at in very advanced glaucoma patients. Patient is counting fingers in the clinic, right? But the patient would subjectively say, "Doctor, my vision is dropping down." If we are not doing the fields right, his complaint will not be corroborated. So we need to follow such patients on 10-2s with a 5 stimulus, or 5-2 with a stimulus 5. If we are not doing it right, we will not up our management. We will not know, because the pressures are 10 or 12 and the fields are the same, but our parameters are not right. So we need to do that. And they have these measures of CETA standard: fast, faster, faster. It's really fast. And whatever standards we have, we need to stick to it to make comparisons. People are making comparisons on CETA standard today with CETA faster 3 months down the road. That's not the right way to do that. Whatever parameters a patient is being followed, we should just stick to it, right? And the other thing is these trend and event analysis. OCT machines have that. Visual field machines have that. Human eye can falsely misinterpret progressive losses. Machines do that for us. But for that, we need a number of visual fields in a year's time. Okay, their handle OCTs, they're pretty amazing resolution, even up to 7 micrometers compared to the regular ones, which is about 3 micrometers. There's even this new concept of portable visual field headset, and there's even newer concept of visual field losses just by looking at the screen of the mobile or even the laptop that we use, and they will just corroborate it. And the machine has the software built in it, and AI does it for us, whether the patient is losing progressive vision or not, just by tracking the eye. Okay, and it's already in phase 2, phase 3. I'll talk about it in next part 2 as well. And yeah, so 4D domain technology has not made its way into clinics, but it is an amazing screening tool, especially when it's very fast, takes a couple of minutes, and really picks up early loss. It has very high specificity. It is not good. It is not a sensitive test. Okay, so RNFL loss precedes the disc and precedes the visual field. This is a normal distribution. And so this is what I talked about. These are the parameters on a regular Humphreys visual field. This is the same patient. Okay, this is what it looks like, right? Same patient. Clinically looks okay, reasonably healthy. Maybe I would keep a watch. I would want to look at his OCTs. But this is his field. This is a healthy 24-2. If I would just have this too, I would just sign off this patient. But look over here. This is the same patient's FAD, and this is the same patient swap. We don't do that clinically. Research centers, research settings, we would do that, quite commonly. This is a classic traditional hill of vision that we all know. Okay, and we have the blind spot. We have to look at it. We have to look at the fixation and the target. And there's even gaze tracking in some, platforms. All right, so this is the nasal step, and it corroborates with the superior area that was damaged. It always has to corroborate. This should be picked up on the OCT, GCIPL, or GCC, whatever module you have. Okay, same thing. Now, if I would just do 24-2, probably miss this, right? 24-2C, I should be able. Now, this disease is severe glaucoma from day one. Okay, the loss might be 5 decibels, but this is severe glaucoma. He already has fixation losses, right? Why? Because of this. This is not the most common presentation of glaucoma, but every once in a while we do get these patients. All right, this is that classic arcuate defects that we all know about. And this is the temporal loss. So everything should just tie up. I pick up this loss on an OCT or an FL, and the fields show this. Okay, all right, and I can probably pick it up clinically as well. All right, so this is glaucoma. Okay, so event analysis. We used to do this commonly over there, but over here I haven't seen that. Because these platforms, these machines, they require more money. So events just tell us glaucoma happens. The disease progression happens in hits. It's a patient could be quite okay for 2 years, and then he would have the hit. There is axonal damage. There's a ganglion cell loss. So it happens in hits, and it happens in episodes. It's an episodic loss. Okay, so this is the rate progression. So the machine tabulates it for us, but we need a couple of machines. So the patient has been stable in this time for visual field index was about 60%. So the machine tabulates over here. The vision is dropping. The machine will just calculate it for us, but we need number of tests for that. It just makes a practice a bit easier and smoother. Okay, so if someone has low loss of visual fields, we would need more visual fields of that patient over over a period of time to establish the growth and the progression and the pattern of the visual field loss in that patient. Compare that to a person who has higher loss of visual field, right? So we can pick that up even with lower number of visual field tests. So this is very nuanced. This is just one of those things that just, so on average, if you ask any person, so they would say in first 2 years, I would like to get something around 6 visual fields to maybe 8 visual fields, to establish the baseline progression of that patient, right? Especially if it's a really young patient, right? So RNFL and ganglion cell loss, and then one gets the visual fields. Okay, all right. So this is the last bit. Let me just quickly go through it, and we have to compare the two discs. We need to know how to look at the disc. Nothing beats it. There are settings where people don't even have access to any OCTs and any visual fields. At the end of the day, it's down to our human eye. Look, IOP will not tell us the loss of glaucoma. Okay, angles can open. Gonioscopy can only tell us if it's open or closed or not. We can establish that very with certainty. Looking at the optic nerve head can tell us that the person has loss or clinically looks like a healthy disc, right? So it's really important. So many people have many algorithms: size, shape, hemorrhages, isn't rule, and peripapillary atrophy. Whatever works for you, have a checklist in your mind. Do it for next 100 patients, and then one can never miss out things. Okay, all right. So, all right. So let me go through this. Right. So step one is to establish the size of the disc. People with big discs, right? Anybody who has more than 2.2 millimeter disc, that's a big disc. People with big discs would naturally have big cups. Cups are pale just by their appearance. We would go to the reverse. Somebody who has this size of less than 1.5 millimeter, that's a small disc. Small discs will have small cups. It is very easy to miss glaucoma out in a small disc. It is very hard to pick it up clinically. So the first thing when we look at the disc is to map out the scleral ring, right? That gives us the idea, and then we look inside at the cup. So the best is, most people don't have access to 60 diopter. Most of us have an access to 90 diopters. So it's about 1.3. So there are these conversion algorithms. Whatever works for you, have a formula. When especially for when someone is kicking this off and they're really getting these fields down, the first thing you look at the disc is to map out the size of the disc. If just by looking at the disc, you know that you're looking at a small disc, you would be more careful over here. Those subtle notching signs and all of that. right? So have an idea. The first thing you look at this is to look at the size of the disc, map out the scleral ring. This becomes extremely challenging in one of those funky eyes, people with extreme myopias, and but even then, sometimes one can make out the scleral ring and then make out the neural tissue, and then one can have the idea of the neural ring tissue. Okay, and the hemorrhages are really important. It comes, okay. Anyways, so second bit is the hemorrhage. If we are not looking at the hemorrhage, so every time I do it is I look at the disc and then I say, okay, now I'm looking at the hemorrhage. I tell myself, okay, now I'm looking at the hemorrhage. If I don't do that, I would miss it out. Why? They're so easy to miss out. And a lot of times, you have to use a red filter to look at it as well, right? So the isn't rule says, and the third step is the third or fourth, depending on whatever algorithm checklist you use, is the isn't rule. In this is not true for all the people. Okay, it's a rule, but it doesn't apply to all the normal, young, healthy individuals. Some people, the inferior rim, it's not more than the superior. It's the other way around. So those are the variations. A lot of times we have glaucoma patients where there's just superior notching, right? And they're just thinning it out over there. So, but most of the time, glaucomatous is because of the distribution of those RNFL fibers. It's usually vertical elongation, right? So one just has to be aware of the variation of the normal rule. So these are all normal discs, right? One is big, one is small, and seems to have a little bit of peripapillary atrophy, right? Peripapillary atrophy does not have a lot of significance in glaucoma in establishing the diagnosis of glaucoma. A lot of myopathists have it, but with glaucomatous loss, the peripapillary atrophy, beta peripapillary atrophy also increases. Alpha is just a variation of both normal and glaucomatous eyes, right? That's one thing. Second thing is look at this disc spirally. So one sees this inferior loss over here. Look at these white striations over here, and when one does this, infrared image, one can easily see this red-free photography that there is this wedge shape loss over here. So this was that heme I'm talking about. Now, if I have a patient, average looking disc, and his every normal disc, normal cup about 0.4, 0.5, and patient does not have any high risk, he doesn't have family history of glaucoma, pressures are normal, angles are open, quite widely open, 40 degrees and all of that, and I would see a heme, I would probably not worry too much about it. But if I have a patient where I have the diagnosis of glaucoma, doesn't matter open, closed, primary, secondary, and I see this hemorrhage, okay, so I'm gonna up my treatment. Why? This is not pathognomonic for glaucoma, but it's a harbinger of, okay, it just tells us that, okay, all right, there's going to be loss. These Drance hemorrhages, disc hemorrhages, they would clear up in a couple of months, 2 to 4 months, 2 to 6 months, they would go away. And if I'm seeing a patient in 6 months, maybe that patient had that disc hemorrhage over there. So every time I would see this, I would up my treatment. I would want to see that patient a bit early. I would just be more active and proactive about it. We'll talk about this in the second part of the lecture as well. All right, same thing. This is just the same patient over 10 years. This is the same patient. This is what happened. This is a healthy, normal, and just look at that progressive loss over there. Okay, so pallor is not glaucoma until and unless proven otherwise. Okay. So this is the last slide, and we need to answer these 6 questions. I cannot stress this enough. It's not like I can miss out one thing and no. Primary versus secondary, open versus closed, thick versus thin. What was the maximum myopia that was ever recorded? Is there evidence on RNFL? We need to know how to pick it up on OCTs and visual fields, and how does the optic nerve head look, and how does it fare clinically? So I'm happy to take any questions if you want to have a break or something.
Is there any significance of laminar time?
What is that?
Is on.
Oh yeah, okay. So when the effacement, when these axons they die out, right? We can actually see through the lamina cribrosa sometimes. I think that's what you're calling it, right? Yeah. So it doesn't really clinically, it's not going to change my management, right? Why? I know this is very advanced glaucoma already, right? If I can see the lamina cribrosa clinically on a patient's eye, right, on my slit lamp, that patient probably already has advanced glaucoma, right? It's not going to change my management. Now, the evidence of these lamina cribrosa and the thinning of the plate and all of that, that's where the research comes into play. They're really looking at, it's that, what came first, chicken versus egg. So they have found that peripapillary area, they've done OCTs, right? OCTAs. And there is, across the board, lesser blood supply, right? The blood supplies just die out because the axons die out, the ganglion cells die out. Now they don't know, we still don't know that what happens first. Is it so? So there's this vascular theory about glaucoma, right? That maybe the vasculopathy. Glaucoma is nothing but a vasculopathy of ganglion cells and RNF and axons. But there's the other thing that this happens as an effect. It's not a cause, right? So yeah, I hope I answered your question.
Thank you so much, very detailed and informative lecture. My question is the quantitative measurement of angle versus role of opening angle and reduce regular iris space. This will be, I think, a very quantitative and comprehensive view of angle. What's your opinion?
Yeah, so I mean, I very briefly touched about it all over the world. People are making use of anterior segment OCT and ultrasound biomicroscopy to really look at the angles. The difference between that is the penetration of infrared is not very good below the iris. So as long as I want to look above the iris, ASOCT will give me amazing detail. If the resolution is as good as even 1 micrometer, okay, I can peep into the Schlem's canal. That's one thing. Second thing is, if I want to look below the iris, okay, I'm giving you a detailed answer. If I want to look below the iris, I would want to do ultrasound biomicroscopy. Why? The frequency is 100 megahertz, 50 megahertz. It penetrates. I can really look behind the iris. And when I would order that, when I have really this funky one quad totally closed, otherwise angles are really open, I want to rule out some, oncology, some ocular pathology, some ciliary melanoma, some, iris cysts or something like that, right? So I would really want to look at the ciliary body and, what's happening behind the iris. That's that. The other thing is, sometimes plateau iris becomes a real challenge, right? So UBM gives us a really good, idea of where the ciliary body lies. Now, how does that translate and replace gonioscopy? Up till now, the experts, there's a big guy, he has published a lot of data on it. He's really big on dynamic gonioscopy. He works out of Mayo Clinic. His name is Cyril. He says up till now it hasn't. In the future, maybe. Why? Up till now, we don't have this dynamic component in any of these tests. The closest thing we have is the light versus dark. I do UBM in a person in the light, and then I make the room really dark, and then I do the same UBM in that patient. Same thing for an ASOCT. I do the person's ASOCT in light, and then I do the same person's ASOCT in dark. And he has published data. And whatever I would see on a gonioscopy, the same thing. But even doing that, the blood vessels in a neovascular glaucoma, okay, if there's new vessels at the angles, that's not picked up, routinely speaking, in ASOCT. Yes, you're right. It gives us a very objective evidence in all the four quads, superior, inferior, temporal, nasal. The ASOCT gives us that angulation, 20 degrees, 30 degrees, and because it's being calculated by machine, it's reproducible. There is no doubt about that. So in future, maybe yes, we might totally get rid of gonioscopy, but for now, it's going to stick around. So yeah, I hope I answered your question.
My question is about the ocular perfusion pressure. Can we detect through OCT
Yes. So we had this world leading researcher working over there with us. His name is Michael Gerard. He's a French guy. He's global authority in this, right? And so he has really produced this amazing data. This becomes all the more important in normotensive glaucomas, right? Yeah, we know normotensive glaucoma, the pathology is just this hypoperfusion, right? We would do sleep studies in these patients if they snore or not. We would do ambulatory night blood pressure monitoring 24/7 of these patients, and we would see this, very high dips of blood pressure throughout the night, right? And if we just fix that, the patients, glaucoma stop, it just gets cured, right? If someone is snoring and sleep study suggests that, just put that patient on CPAP and there is no glaucoma anymore. So yeah, but it's a very active area of research right now. Any other questions? No questions? That's it? Okay.
Thank you so much, Dr. Nabeel. That was really incredible. Now, I would only request Professor Dr. Nabeel to kindly come forward and share your valuable feedback and experience like on the first part of
Good morning, dear colleagues, ladies and gentlemen, and students. Um, it's really nostalgic and very sort of. I'm very happy to be here again after a gap of a few months when I was serving here as principal. Then the department was under renovation, and now I've come today after it has been completed, and really delighted to see everything very nicely placed. As regards the glaucoma is concerned, it's always challenging, and always we're looking for new information. New The definition is itself evolving every 5 to 10 years, and Nabeel has very well covered the first part of the glaucoma diagnosis, and I think in the second part he will be talking more on the solutions and the treatments. But the first part was very comprehensive, and he's touched almost every aspect of diagnosis, starting from the anterior segment examination to the level of OCT and different types of OCT and different interpretations of OCT and anterior segment OCT. So his lecture was really comprehensive, and especially for the beginners also, and for the ophthalmologists also, that covered everything. So well done, Nabeel, and we are very happy to have you here. And I also welcome Arshad here with us. He's head of department, Al Alim Medical College and Gulab Devi Trust Hospital. And our colleagues all, हमारे पास हमारे दोस्त जो पुराने हमारे साथी हैं, सब लेक्चर्स में आया करते थे, आज वो भी आए हुए हैं. तो I think this activity itself is very heartening that it has been revived in Jinnah and in Allama Iqbal Medical College, that we are all attending a lecture by somebody who has worked hard on it, learned in a hard way, worked for many years in Singapore National Eye Hospital, did this PhD and learned a lot of things there. सो ये बहुत ही अच्छी एक्टिविटी है, और इंशाल्लाह आपकी एक्टिविटी आगे भी चलती रहेगी. और ये बड़ा अच्छा है कि आप इसको ऑनलाइन भी दे रहे हैं, लोगों को लिंक दे रहे हैं, क्योंकि वर्किंग आवर्स में सब लोग अपने अपने हॉस्पिटल में बिजी हैं. तो अगर कोई टाइम किसी को मिल जाए तो बजाय वो ट्रैवल करके यहाँ आए और आके अटेंड करें, उनको ये फैसिलिटी है कि वो अपने फ़ोन पे या अपने लैपटॉप पे इसको देख सकते हैं. सो वेल डन हमाद, काशिफ, Madam Uzma, Irfan, Samreen, and all the colleagues here, जो हसान हैं, तो जो काम कर रहे हैं यहाँ पे, जिन्होंने इसको प्लान किया और एग्जीक्यूट किया. तो थैंक यू वेरी मच फॉर इनवाइटिंग मी आल्सो and making me part of this activity, especially for glaucoma. अभी ये सिलसिले चल पड़े हैं, अभी चल रहे हैं. 26 तारीख को आई एम इन्वाइटेड एट एवेसीना, खालिद ने बुलाया हुआ है, वहाँ पे वो भी लेक्चर कर रहे हैं बेसिक से एडवांस अपनी फैकल्टी को पढ़ाने के लिए. तो मैंने कहा यार वो सारे आई के तो नहीं होंगे, तो फिर वो ग्लाकोमा उनको कितना समझ आएगा. तो कहता है कि हम भी तो गायनी के लेक्चर बैठ के सुन लेते हैं हमें कितना समझ आता है, तो जितना हमें आता है उनको भी आ जाएगा. तो ये अब एक्टिविटीज, आपको पता है ये मौसम जो है ना, ये कॉन्वोकेशंस और कॉन्फ्रेंसेज और वर्कशॉप्स का मौसम है, ये फरवरी मार्च तक चलेगा, तो उसके बाद फिर रोजे शुरू हो जाएंगे तो कुछ थोड़ा सा सिलसिला रुक जाएगा. So anyway, I think it's a very good activity. I really enjoyed listening to Nabeel, and Nabeel was very comprehensive and talked everything in detail, and he was very fluent also. That actually shows that he has got good grasp on the subject, good hold on the subject, and that only comes by practically working. ऐसे थ्योरी पढ़ के इधर से उधर से आप इस तरह से नहीं कर सकते जब तक आपको खुद आपने अपने हाथों से सारे काम ना किए हुए हों और सीखे ना हो. तो ग्रुप पे जो भी कुछ कहा जा रहा है, आई टोटली नेगेट दैट, एंड दिस इज रियली good that he has come back to Pakistan with his qualifications and experience, and he will be working here in Lahore. So he will be a good asset for ophthalmic fraternity and good for the patients of glaucoma. Thank you very much. बड़ा तुसी स्टैंडर्ड चुके हुए हैं, तहजीब ये.
Thank you so much, sir. Now we are going to have a short tea break. Kindly come outside and join us, followed by the part 2 of this lecture. Thank you so much. Please join us for a short tea break.